Hello and welcome. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us today for one of three CMEO snacks titled Joining Forces in the Coordination of Care of Patients with Psoriatic Arthritis. This CMEO activity is supported by an unrestricted educational grant from Bristol Myers Squibb Company. I'm Alan Gabowski, professor of medicine at Weill Cornell Medicine and attending rheumatologist and co-director of the Clinic for Inflammatory Arthritis at Hospital for Special Surgery in New York. I'm joined today by Dr. Anthony Fernandez, Director of Medical Dermatology and the W.D. Steck Chair of Clinical Dermatology in the Departments of Dermatology and Pathology, Dermatology and Plastic Surgery Institute of the Cleveland Clinic in Cleveland, Ohio. Welcome, Tony.
Thank you, Alan. It's a pleasure to be here talking with you today.
Today's activity is eligible for ABIM Maintenance of Certification credit and also as a CME for MIPS improvement activity. If you are claiming it for Maintenance of Certification credit, be sure to fill in your ABIM ID number and date of birth on the evaluation so that your credit can be submitted to the ABIM by CME Outfitters. If you wish to submit for the CME for MIPS, then over the next 90 days, actively work to incorporate improvements in your clinical practice from this presentation, and then complete the follow-up survey from CME Outfitters, which you will receive in approximately 3 months. CME Outfitters will then send you confirmation of your participation that you can submit to CMS, attesting to your completion of a CME activity for the MIPS improvement program. Our learning objective today is to coordinate care with specialty and primary care colleagues so as to optimally co-manage patients with psoriatic arthritis. So Tony, let's jump right in. Where does the diagnosis of psoriatic arthritis begin?
It's a great question, Alan. Well, as you know, about 30% of all patients who have psoriasis will eventually develop psoriatic arthritis at some point during their disease course. And there are different patterns in terms of onset of skin disease and joint disease. Patients may present with psoriatic arthritis prior to the onset of skin lesions. They may present with psoriatic arthritis at the same time as onset of skin lesions, or the psoriatic arthritis may begin after onset of skin lesions. And a wealth of research has suggested that far and away the most common pattern of onset is that patients will develop the skin disease prior to the onset of joint disease. And in some of these studies, the lag time between onset of skin disease and joint disease on average is as long as 10 years. So we think it's important for dermatologists to at least play a role in screening patients with psoriasis for the potential onset of psoriatic arthritis at every single clinic visit.
Tony, does that tell us anything about delays in the diagnosis of psoriatic arthritis over that interval?
Another great question, and there has been research looking at that. And there are no definitive answers, but there was an interesting abstract that was presented at the 2020 American College of Rheumatology meeting. And in this study, the researchers looked at 162 patients with an incident diagnosis of psoriatic arthritis. And they retrospectively reviewed their charts to try to identify different factors that may contribute to a diagnostic delay. Well, the one thing they found in this cohort is that a median lag time between the onset of symptoms suggestive of psoriatic arthritis and a diagnosis was 2.5 years. So quite a delay on a median level from onset of symptoms to making a definitive diagnosis of psoriatic arthritis. About a quarter of those patients were diagnosed with psoriatic arthritis 6 months following onset of symptoms, but even at 2 years, only 45% of those patients had a diagnosis of psoriatic arthritis. And when they looked at different factors that may contribute to a delay in diagnosis, they found that patients who were diagnosed at a younger age, patients who had a high body mass index, and the presence of enthesitis before a diagnosis were all associated with a greater delay in making that diagnosis, whereas the presence of SIBO psoriasis was actually associated with less likelihood of delay. Now, I'm trying to interpret this in the setting of a dermatologist's office, if that's where these patients are coming up with their symptoms. And it may be that patients who are younger, patients who have a large body mass index, so maybe obese, or patients who have enthesitis, which, as you know, is difficult to pinpoint just visually on physical exam or even doing a physical exam maneuver, even for rheumatologists, that dermatologists may be attributing those symptoms to something other than inflammatory joint pain. But I think the real answer is that we need more work, but it is important work, Alan, to try to figure out if there are factors that can play a role in delay, and if we can close that gap somehow by identifying those factors so that these patients can more promptly be given a diagnosis and started on treatment that will inhibit permanent joint damage. But Alan, as a rheumatologist, when you are evaluating patients with psoriasis who may be complaining of joint symptoms, what are you looking for that helps you make a diagnosis of psoriatic arthritis?
Well, it's a little bit easier because if the patient is referred to me with psoriasis, then I already know that I should be looking for an inflammatory condition in these patients complaining of joint pain. A challenge occurs in patients who are referred to me for the management or evaluation of arthritis, where no skin lesion is visible. And if they have a negative rheumatoid factor, which I'll get to in a second, as one of the hallmarks of our workup, then my challenge in patients who have a negative rheumatoid factor, who are so-called seronegative, is to disrobe them completely at each visit to look and see if they are in that minority of patients who are going to present with joint pain and then develop their psoriasis. But coming back to the question you asked of what am I looking for in a patient that has been referred to me by the dermatologist with a known diagnosis of psoriasis, I'm going to be looking for the signs and symptoms of inflammatory joint pain, such as morning stiffness, joint pain that improves with activity rather than gets worse by it. I'm going to be looking for swollen and tender joints, dactylitis, the so-called sausage-shaped deformities, enthesitis, the inflammation of where a tendon inserts onto bone, particularly the Achilles tendon. Achilles tendonitis is fairly common. I'm going to be looking for inflammatory back pain, which may be a harbinger of the axial phenotype of psoriatic arthritis. I'm going to be asking about and looking for any complaints of inflammatory eye pain, uveitis, which frequently goes along with psoriatic arthritis. And then, of course, I may do imaging studies looking for characteristic findings such as joint erosions and juxta-articular destruction, particularly in the hands and small bones of the toes. I may be looking for ankylosis of the disc spaces of the lower back if I'm looking for the axial phenotype. And the other important thing is to recognize that joint involvement may not be at the same location where skin involvement is, and not at the same time as skin involvement. So all of these things are going to help me look for an inflammatory arthritis rather than just aches and pains in a patient with psoriasis that may be more mechanical and degenerative than inflammatory. I may be helped somewhat by applying the CASPAR criteria. Now, the caveat is that the CASPAR criteria are for the classification of psoriatic arthritis. And classification criteria generally should not be used diagnostically. Classification criteria are used to stratify and come up with homogeneous populations of patients to enroll in clinical trials. Nevertheless, applying them to individual patients can give us a certain degree of confidence into whether we're going down the right path in the entity that we think we're trying to define. So if a patient has inflammatory musculoskeletal disease, such as arthritis, spondylitis, enthesitis, and has a certain point score, which is related to evidence of psoriasis. And if you've sent them to me, they certainly do. But I may be seeing them before the skin lesion develops, in which case I'm going to be asking about a history of psoriasis. I'm going to be asking about a family history of psoriasis. I'm going to be looking for nail changes. I've already alluded to the importance of the seronegative rheumatoid factor test. I'm going to be looking for changes in the shape of the fingers or toes, and the imaging studies that I've alluded to earlier as well, all of which may help me go down the road towards a diagnosis of psoriatic arthritis, either axial or peripheral. But Tony, while we're on the patient, I'm reminded that you partnered with a colleague of mine, Elaine Husney at the Cleveland Clinic, to do a survey of patients with psoriatic disease symptoms. Can you tell us a little bit about what you came up with?
Sure. Yes, you're absolutely right. We were involved in a study together called the Disconnect study. And that was a survey study. And the survey consisted of asking both patients and physicians to rank a number of symptoms related to cutaneous psoriasis or psoriatic arthritis in terms of importance, in terms of how bothersome they were to the patient. There were over 200 patients, I believe, who were surveyed, as well as over 100 dermatologists and rheumatologists. And we learned a lot from that study. So the one thing we learned is that luckily, patients, dermatologists, and rheumatologists all agreed that joint pain, soreness, and tenderness was among the most important bothersome symptoms of psoriatic disease. But interestingly, we also learned that there were differences among patients, dermatologists, and rheumatologists. Patients, believe it or not, ranked skin pain, inflammation, or broken skin as the most bothersome symptom of psoriatic disease. And the other difference we found is that, as you may imagine, relative to joint pain, rheumatologists had a tendency to rank other joint symptoms as being more important and bothersome, whereas dermatologists had a tendency to rank skin symptoms as being more important and bothersome. So I think the take-home message from the Disconnect study was, number one, that we need to recognize that it's all in the point of view, and patients may think of symptoms being more important to control than either rheumatologist or dermatologist. And that probably the best approach is for rheumatologists, dermatologists, and of course the patient to all communicate with each other and work together to come up with a treatment regimen that will best address the patient's psoriatic disease. But that study, of course, Alan, focused mainly on symptoms of cutaneous or joint involvement with psoriatic disease. And I was wondering if you could tell me, what are some of the common comorbid diseases outside of the skin and the joints that you see in patients with psoriatic arthritis?
One of the things that is often forgotten is that psoriatic arthritis is a systemic disease. It may primarily affect the joints, but there are manifestations both primarily and secondarily elsewhere in the body. One can have ocular inflammation, uveitis, and iritis. One can have an impact of the psoriatic inflammation on the gut. Or conversely, we can see patients with inflammatory bowel disease have joint abnormalities. The psychosocial burden is significant in patients with psoriasis, as you well know, as well as patients with psoriatic arthritis. Manifestations of anxiety, depression, suicidal ideation, and substance use appear to be somewhat higher in patients with psoriasis and psoriatic arthritis than the general population. And then, because this is an inflammatory disease, and one of the manifestations of un or under controlled inflammation is cardiovascular disease, we often see hyperlipidemia, hypertension, insulin resistance, diabetes, and obesity in these patients. Now, whether the hypertension is a function of obesity, whether the diabetes is a function of obesity, whether the obesity is somehow related to the psoriasis. All of these are remaining to be teased out in cohorts and in individual populations. But nevertheless, these are common comorbidities in our population of patients with psoriasis, as well as patients with psoriatic arthritis. If we focus just on the components of the mental health exam, we know that individuals with psoriatic arthritis have a 2/3 greater odds, or 66% higher odds of having prevalent depression and a 49% higher odds of having prevalent anxiety compared to individuals without psoriatic arthritis. So we certainly need to be attuned to the physical manifestations and comorbidities, but we need to be attuned to the mental components of our patients and the mental comorbidities of psoriasis and psoriatic arthritis as well. But the presence of comorbidities is probably a good segue, Tony, for the need to at least touch on the need for a multidisciplinary approach to the management of psoriatic arthritis. Tony, what's your perspective in dealing with the number of participants in the healthcare team?
Yeah, no, I think you're absolutely right. And I think the comorbid diseases that you've highlighted so well, and recognizing and understanding that psoriasis and psoriatic arthritis, especially in their moderate to severe forms, really represents systemic inflammatory diseases that can be associated with numerous comorbid diseases, point out that in order to have an optimal therapeutic approach to a patient with psoriatic disease, you really need a team. And that team, of course, often consists of a rheumatologist and a dermatologist, but a very good primary care provider can be indispensable, somebody who can really make sure that they are monitoring for dyslipidemia, insulin resistance, making sure that blood pressure is controlled. And patients who have a significant psychologic impact, having a psychologist or even a psychiatrist on the team can make a tremendously positive impact on that patient's outcome. And then a number of other providers, dietitians, cardiologists or preventative cardiologists, and gastroenterologists if the patient has inflammatory bowel disease. So we tend to develop teams based on the individual needs of the patient. And I think that's very important.
Yeah, I think you've really outlined the various participants, but we have to be careful not to forget the pharmacist, because in every condition, particularly with the medications that we're dealing with that often require prior authorization and concurrent authorization and post-use authorization, the pharmacist is an indispensable member of our team because they have resources and can be a valuable asset related to the prior authorization burden with our medications. They can offer resources for patient monitoring, for medication management and reconciliation. And I'm reminded of a study that pointed out that in a number of insurance denials, nearly 3/4 of denials that were challenged by pharmacists were overturned. And the average time of denial to approval was only 9 days. So we really need to include the pharmacist, who can be indispensable both for us and for our patients.
I think that's a great point, Alan. It's very important to be able to get the medicine that the team believes would be the best for that patient, and pharmacists can really be helpful in making that happen. But I was wondering if you could share, once you are seeing a patient that you start on treatment with psoriatic arthritis, what is your workflow in terms of monitoring patients who are being treated in your practice for psoriatic arthritis?
Well, again, if the patient has been referred to me by a dermatology colleague, I'm going to be focusing primarily on the joint evaluation. But if they have not been referred to me by a dermatology colleague, and I'm still thinking about the possibility of this inflammatory arthritis being psoriatic in nature, even though nothing is visible in the initial evaluation, at each subsequent visit, I'm going to ask them to disrobe completely. I'm going to look in the gluteal area. I'm going to look at the umbilicus. I'm going to look in the scalp. I'm going to look in the intertriginous folds. I'm going to look in the genital area in order to be certain that this patient is not in that minority who begins with psoriatic arthritis, sine psoriasis, only to develop it at a later evaluation. I'm going to be looking for other things on the skin that may be the result of inflammation, but here I'm going to be relying on you and your colleagues for things like skin cancer screening and the impact of their skin burden on the health-related quality of life. I'm certainly going to be asking them about their past personal history or family history for psoriasis, if indeed I'm still suspecting that this might be an inflammatory disease that is going to blossom into psoriatic arthritis. And above all, I'm going to be in constant communication with my dermatology colleagues, because if there's a decision to put the patient on biologic therapy, the logistics of administration are probably best managed by both of us rather than one alone. So let me take a minute just to summarize what Tony and I have been discussing for the last several minutes. We want to recognize the impact of delays in diagnosis on joint damage and patient health-related quality of life. We want to incorporate patient-reported outcomes as part of shared decision-making, and we definitely want to employ a multidisciplinary approach to coordinate care for patients with psoriatic arthritis. Obviously, we want to monitor patients with psoriatic arthritis for their psoriatic burden, if present, or if not present, if developed at each visit. This CME Snack is one of a three-part series, and we sincerely hope that you'll take advantage of all the short and focused activities in the series. These activities and a wide variety of activities and resources on inflammatory disorders are available on the CME Outfitters Psoriatic Arthritis Education Hub for both healthcare providers and patients, and the link is on the screen. Finally, and again, to collect credit for today's activity, click on the link to complete the evaluation, and you'll then be able to print your evaluation certificate from the platform. Thank you for joining us today. Whether you are a rheumatologist, dermatologist, or primary care provider, I hope we gave you some ideas and strategies to improve your coordination of care for your patients with psoriatic arthritis.